I'll invite the next speaker, who's also the chief instructor of this IC, Dr. SHWETA Agarwal. And I think her area of interest is very vast. She does right from the surface to the endothelium, I think, and that's why this IC. But she's going to teach us about therapeutic penetrating keratoplasty without surgical adjunct, surgical pearls.
Thank you so much, Rishi. And coming to the last talk of this IC, well, therapeutic keratoplasty, when, what, and how to do. Well, we all know that TPK is usually done in patients with infective keratitis. In cases where there is worsening despite a maximum medical therapy, where there is an extensive corneal involvement, a threat to global integrity, or corneal perforation, or the patient is presenting to you with a scleral involvement. The primary goal is to debulk or eliminate the microbial load to restore the structural integrity. Secondary would be a visual rehabilitation. Well, a lot of factors which will influence your surgical plan, starting with the age of the patient, the extent of infiltration, whether it is limbal, scleral involvement is present, not there, infective organism, how resistant it is, and presence or absence of impending melt or perforation. Now, these are the basic steps when we talk about a therapeutic keratoplasty, and let us go through each one by one. Beginning with anesthesia. So if you have a patient who's a child or an anxious patient, or a patient's presenting you with a large perforation or a large graft, post-victimized where you're expecting too much of a thrust, a general anesthesia would be preferred. Otherwise, you can go ahead with a local anesthesia. Flaringa, well, it is primarily used in patients with perforated eyes, in eyes with larger grafts, impending perforations, and post-victimized. Well, at SM, we prefer to use a Flaringa in most of our cases. And how do we do it? We can use either the nylon or 7.5 thread, and what you are using are 4 to 6 to make sure that the sclera doesn't collapse. And the size of the Flaringa can be 2 to 3 millimeters larger than your graft toe junction, so that it doesn't interfere with your suturing. Well, if you have patients presenting you with a pseudocornea or a perforation, before you go ahead with trephination, some kind of tectonic support will help stabilize the globe. So you can use either a cyanoacrylate glue, or in this second patient down that we are seeing, this patient was a case of chemical injury who presented to us with a large perforation of around 6 millimeters. His lower edge or the lower limbus was stuck to the lower lid. Now, before we would do a therapeutic and we would need the inferior limbus to suture the graft, we had to release the inferior symblophron. So here we sutured the bandage contact lens to the perforation to give the tectonic support, and then went ahead with releasing the inferior lid and then a routine therapeutic graft. Now, as far as the trephine size is concerned, as in the host, you need to involve the entire involved area, a 0.5 to 1 millimeter clear margin. As far as the donor is concerned, again, 0.5 to 1 millimeter larger than the host. It'll help facilitate better formation of the anterior chamber. And again, any graft size more than 10, we prefer a difference of 1 millimeter, again, for a better anterior chamber formation with a larger graft. So the trephine size and location varies with the size of the infiltrate and the site of the infiltrate. It could be central, it could be peripheral, it could be eccentric, it could be total. Now, lens. You really want to preserve the lens because you don't want the anterior and posterior chamber to become one and the infection to trickle from the anterior to the posterior cavity. You can, if it's a phakic patient, you can give the patient a pre-op IV mannitol to reduce the vitreous thrust, a Flaringa to prevent a sudden collapse, and a careful peeling of the inflammatory membrane in the pupillary area so that we don't open up the anterior capsule. Exceptions, however, are patients who present to you with a perforated ulcer or a pseudocornea with the bulging lens or an intumescent lens, where we would have to sacrifice the lens to form the chamber. But in such cases, again, we would try and see if we can keep the posterior capsule intact. Now, all these eyes are significantly inflamed and they will develop some kind of angle closure glaucoma secondarily. So you would prefer to have 2 large iridectomies. You can use either a Vanna scissor or a vitrectomy cutter to make that. Donor suturing is always interrupted. These are inflamed eyes with irregular healing, so you do not want a continuous suture. You can use either a 10-0 or a 9-0 nylon, and this number depends upon the size of the graft. Anything less than 10, usual recommendations are 8 to 12 sutures, 7.5 to 10 millimeter grafts, 16 sutures, and anything more than 10 millimeter would be around 24 sutures. Again, this gives a better convexity and a better formation of the anterior chamber. Now, the basic steps that we just went through, a video summarizing that. You first measure the size of the infiltrate, a 0.5 to 1 millimeter larger. Anchor the flaringa with a deep episcleral bite using an 80 nylon. Trephine the host bed. We usually don't want to go a full thickness in an inflamed eye because most of the times the anterior chamber is shallow to flat. Careful entry. Inject visco to form the anterior chamber. Excise the host button. Very careful peeling of the pupillary membrane so that we don't open up the anterior capsule. This is really important. You need to remove this, otherwise the patient will end up with a pupillary block glaucoma. A good large iridectomy, 1 or 2. And then suturing of your graft with either a 9O or a 10O nylon. Since this was a larger graft, we have taken 24 sutures. And bury your sutures and remove the flaringa. Well, we do have some special case scenarios, patients with endophthalmitis where you might have to do a therapeutic graft with your VR colleagues. In such cases, we prefer a general anesthesia because the surgery is going to take a little longer time and you would need a temporary capro. What we need to remember is the sizes which are available as of now are 6.2, 7.2 and 8.2. So you need to plan your surgery accordingly. Well, the capros that are temporary capros that are available are silicone and the landers or the PMMA. The silicone is a soft, pliable keratoprosthesis, whereas the PMMA or the landers is the hard or the rigid one. Multiple uses is going to cause scratches in landers and it might result in torn edges in your silicone capro. The suturing in silicone capro is much more easier. It just goes inside into the graft, into the defined edge, and is to the defined edge of the host. But the PMMA is a larger capro, so you need to suture it wherever your end of the capro comes out. It facilitates a more clearer view of the posterior chamber and helps the VR colleague finish their part. After that's done, just remove the temporary capro and go ahead with the routine TPK that you have planned for. Now, if you have a patient with a refractory organism like pythium keratitis, or you have a limbal involvement, or you have patients presenting to you with a recurrent infection following a therapeutic graft, what we usually advise is a TPK with surgical adjuncts, that is a cryo-alcohol therapy. Here we swab the involved surface with a 99.9% alcohol for 30 to 60 seconds and use the nitro oxide cryotherapy, the same that our VR colleagues are using. It is a retinal tip that we use. We place the probe for around 7 to 8 seconds for an ice ball of around 1 millimeter to form around the tip, followed by a slow thaw. The video just showing that the absolute alcohol soak swab is just moved around the area of involvement. Wash it, measure the area of involvement. This was around a 17 millimeters graft therapeutic that we were doing. A single freeze thaw cryotherapy at the edge where we are going to trephine. And once this is done, this is followed by a routine therapeutic graft, a flaringa, and the routine surgical steps that we do. Excise the host button and replace it with your donor graft after doing a good iridectomy. This patient was phakic and we were able to salvage the lens. To summarize, we all need to plan our surgeries well. You have to anticipate complications. A pre-op counseling plays again an important role in patients with therapeutic where they need to understand about the possibility of recurrences and that the graft is not being done for vision. It is being primarily done to debulk the infection. A timely intervention will definitely help us improve our outcomes. Thank you so much. Any questions?
Ma'am, which suture do you use to secure temporary capro?
70 Vicryl.
For your sclerocorneal graft, you're using 80?
90.
90.
90.
Very nice talk. Do you use the adjuncts in every case of pythium keratoplasty?
Yes, Rishi. Now that we have enough of our cases to show that it really works, if we are doing a therapeutic graft, definitely yes.
Only for pythium?
Only for Pythium. And if we have a patient presenting to us with a recurrence, we have
Right.
done cryoalcohol therapy for patients with acanthamoeba. We have done cryoalcohol therapy for very refractory fungal scleritis, where almost 360 degrees the patient had presented to us with a fungal scleritis, one-eyed patient, and because of cryoalcohol therapy, actually, we were in a stage where we were going to eviscerate the eye, but we thought, okay, one last shot, and we were still in those early stages where we ourselves didn't have full faith on the cryoalcohol therapy, but we were able to salvage that eye, and he's 6'9" now.
Lovely. That's
Yeah.
nice to hear. So, do you think we could use these principles even say you're doing a scleral deroofing for a fungal scleritis, which is very focal? Could you
Absolutely.
just apply alcohol and do a
Absolutely,
little focal
absolutely.
cryo in that area?
Absolutely. In fact, after
Yeah.
that case, we have started doing it. So patients with a fungal scleritis,
Yeah.
when we are taking up the patient, you are anyways taking up the patient in the OT, and alcohol is something which is readily
Universal.
available. It's very cheap and keeps everybody happy. So yes, we use it very often in OT, especially with patients with fungal scleritis.
Thank you.
Thank you.
And what is your post-op regime in therapeutic PK done for fungal etiology?
Fungal keratitis patients will be on natamycin, or we usually start with one drug. So it'll be natamycin every 1 hourly, and along with cycloplagics and lubricants. If required, voriconazole, based upon if we've been, if we have done a sensitivity and we have found something. Otherwise, usually natamycin or voriconazole. And pythium, we as of now post-op give the patients topical azithromycin and linezolid.
Do you have any experience of using cyclosporine in post-op?
Yes, we do use, especially in patients, even after the cryoalcohol therapy, we have noticed that some of these patients develop a significant inflammation intraocularly, and we use 2% cyclosporin 3 times or 4 times a day in patients. Even post-therapeutic, if especially fungal TPKs where you have too much of intraocular inflammation, we've been using cyclosporin 2%, and it works quite well. Thank you.